Well, thank you very much for the opportunity to talk about emerging and current therapies for Hodgkin lymphoma. As I start off, I just want to remind us a little bit about some key biology, which many of you might be familiar with, but you'll see it's pertinent to what I'll talk about as we're thinking about new therapies. So the image you're seeing here is really highlighting three things. Number one, if you look at the top two figures, you'll recognize the Reed-Sternberg cell, the owl eyes that you might remember from medical school. But you can see arrowed in the top left the number of Reed-Sternberg cells. And just to remind you that they are only 1 to 5%, the minority of cells, and most of what's in the tumor is an inflammatory infiltrate. What you can see on the bottom left, is staining for CD30. So Reed-Sternberg cells are exquisitely CD30 positive, and that's important because brentuximab vedotin, which we'll talk about, targets CD30, delivering MMAE to those cells. What you're seeing on the bottom right is something that you also would be familiar with, and that is the Reed-Sternberg cells have copy number gain and amplification of chromosomes 9p24.1, and what you're seeing is overexpression of PD-L1 and PD-L2, and the PD-1, PD-L1, and PD-L2 interaction can be interrupted by PD-1 blocking antibodies, which are also part of our changes of therapy. The other thing that I just want to take a minute to remind you about is the staging of the disease. So Hodgkin lymphoma patients are separated into limited stage, and within limited stage, based on the prognostic factors, into favorable patients and those that are unfavorable. I think in general, if you take things away from today, just remember that favorable patients are really very favorable. So don't get caught into too much of just there's a little bit of disease that looks good. Really favorable patients have very limited number of lymph node sites, and so I think it's always better in practice to err a little on the side of more treatment rather than less. The second thing that I think is important to know is that in advanced stage disease, really, although there are prognostic factors, most of what we do is driven by PET response. So pretty much a good response on a PET scan is of greater prognostic significance than factors at the time of diagnosis. So what I hope you have straight in your head right now is limited stage, favorable, unfavorable, and advanced stage being the three main categories that we'll talk about in frontline therapy. So if you were to take those three categories and kind of think about what is the standard, because if we're going to talk about emerging and better therapies, we need to say, what are we comparing it to? So the first thing is that if you have a patient who has limited stage favorable disease, what is kind of the standard? And I think based on older studies, the HD10 trial from the Hodgkin lymphoma study group from Germany would say that you can give 2 cycles of ABVD chemotherapy and 20 gray of involved field radiation treatment and have excellent outcomes. If you have unfavorable characteristics, you would increase the numbers of rounds of chemotherapy to 4, that's 4 cycles of ABVD, and you would give 30 gray. As I'll show you in a minute, a lot of work has been done to say, do you really need radiation treatment? Based on the PET scan, if you have a good response after 2 cycles, data from the RAPID trial would say that you can just give 3 cycles of ABVD chemotherapy and omit the radiation treatment. And then if you're thinking about Hodgkin lymphoma advanced stage, standards in the past had been the use of ABVD chemotherapy with dropping the bleo, the addition of brentuximab plus ABVD chemotherapy, or escalated BIACOP, and as I'll show you in a minute, the use of nivolumab in the Nivo-AVD combination and the use of BRIA-CAD rather than escalated BIACOP have really changed how we think about managing advanced stage patients. So I want to start us off just talking about limited stage Hodgkin lymphoma. Remember how I said that there would be chemotherapy with or without radiation treatment, depending on whether you were favorable or unfavorable. This is the results of the RAPID trial, now almost 10 years ago, pretty much showing, reported 10 years ago, but run even longer than that, showing that if you take patients and check a PET scan and look at their results, if they are in a remission, you can actually stop and not give any radiation therapy. And at ASH this year, an update now with 16 years of follow-up have shown that there's no difference in the overall survival of these patients. will say that when the study was initially presented, there was a slight decrement in the progression-free survival, in other words, the number of patients relapsing, if you omitted the radiation treatment. So I wanted to take a minute just to put a cautionary tone into our discussion today. When that data came out in 2016, at our practice, we made a practice change. We decided to omit radiation therapy based on the results. But 10 years later, we went back and looked at our results, and we actually found that omitting the radiation was significantly inferior, as you can see by the red line. And you might go, well, what happened there? Well, it turned out that in practice, we liberalized the characteristics. We had more bulky disease, more unfavorable patients than were in the trial, and omitted radiation based on the PET scan, and got inferior results. So that's just a cautionary note to say, stick with the trial design criteria if you want to get the same outcomes. So, moving forward, what's new and what are the next steps? And I'm going to show you 3 different strategies where leaving or making changes to treatment are improving outcomes. So the first is, if you leave out the radiation therapy, could you do something instead using some of these new agents to get excellent results? So in this trial, this is about 83 patients. Brentuximab vedotin AVD chemotherapy is given through 3 cycles, similar to the RAPID trial. An evaluation, if PET negative, consolidated with 8 doses of nivolumab. If PET positive, intensified a little bit, receiving brentuximab plus nivolumab. The important thing here to see is that the outcomes were outstanding, suggesting that maybe in the future, will require a randomized study, the use of these novel agents could actually augment the results. This was taking nivolumab and including it into the strategy of the German Hodgkin lymphoma study group. So in this study, randomized comparison with using either concomitant Nivo-AVD or sequential, give Nivo first and then AVD afterwards. Notably in this case, everybody still got radiation, but the point I would make here is that the outcomes are outstanding. I don't think you can get a better Kaplan-Meier curve than this one, just again to show that this strategy in limited stage patients is excellent. Well, what about if we took all the agents that we know are highly effective and just used them all together in frontline therapy? So taking the 2 most active chemo drugs, that's dacarbazine and doxorubicin, and add brentuximab and nivolumab all together in limited stage patients, what would the outcomes look like? And as you can see, again, this is a phase 2 trial. Results look outstanding, suggesting that that may be a strategy for the future, but clearly would still require randomized comparison. Now I want to turn our attention to advanced stage patients. So again, you might remember I showed you there were a number of different strategies. One of those strategies is to use ABVD chemotherapy, give 2 cycles of treatment, check a PET scan. If the PET scan is negative, drop the bleomycin and complete 6 cycles. The RATHL trial looked at that strategy compared to just straightforward 6 cycles of ABVD chemotherapy and showed that there was no difference if you were PET negative if you dropped the bleomycin. I will point out, though, that if you were PET positive, was a little more tricky because it wasn't clear that using a more aggressive approach at that point really made the curves a lot better. But what did that take us on to? So the next step was to say, well, instead of just dropping the bleomycin, could we improve the entire group of patients by using one of the new drugs, in this case, brentuximab vedotin? So brentuximab vedotin plus AVD chemotherapy compared to ABVD, first of all, showed a progression-free survival, and then with longer follow-up, showed an overall survival. So just like Michael told you in the previous talk, that was pretty unusual. Because remember, we've always said that you can salvage everybody with chemotherapy and a transplant, and so it might not matter that much what you did in frontline. But everybody got salvage and a transplant, and yet what you did in frontline actually seemed to have made a difference. The next thing to note was that in Germany, they took a look at escalated BIACOP, and then looked to see if they could modify it by actually making it less toxic. So they changed it to BRICAD, which is less intense, utilizing brentuximab vedotin, and they compared it head-to-head to escalated BIACOP. Two takeaways from that study. Number one, it was less toxic for sure, not still non-toxic, but less toxic. And secondly, it showed a better progression-free survival compared to escalated BIACOP. So message from that was, escalated BIACOP is dead, and BRIACAD has really taken its place. But back in the US, the next step was to take nivolumab and use that in combination with AVD chemotherapy compared to brentuximab AVD chemotherapy. And that data, now with longer-term follow-up, these results continue to hold up, showed an improvement in progression-free survival, not yet an improvement in overall survival, but definitely an improvement in progression-free survival for nivolumab over brentuximab in combination with AVD treatment. I think what has been very valuable about this data is that when one looked at the elderly patients, you saw very clearly here that nivolumab was better tolerated and certainly better outcomes, mainly I think because patients could remain on this trial. I think in the spirit of what we discussed at this meeting, this was one of the few studies, by the way, that really incorporated a far more diverse population, really got on predominantly patients from all population groups, which I think is a notable thing, not only the young and the old, but really across all population groups. Similarly, in the younger patients, as I mentioned, an advantage for receiving nivolumab AVD over brentuximab AVD. So finally, what could you do? Just take all the drugs and put them together, similar to what I showed you in limited stage. This is a small study, but again, just to point out that in advanced stage patients, this is feasible, tolerated, and very effective. Whether it's better than just nivolumab AVD alone will require a randomized trial. So I want to move now to the second line. So if you've done those kinds of therapies, I will tell you it does really impact what you do subsequently, and I will say that it's a little challenging sometimes to make recommendations because you'd need to go back and look at what happened in frontline to select wisely subsequently. But I will make a few points. So the addition of PD-1 blocking antibodies in second line with chemotherapy prior to going to transplant seems to make a substantial difference to patients' outcome. So here are a number of studies that show, phase 2 studies, that this is effective. This is Pembro plus GVD in second line, showing high response rates in the majority of patients going to transplant. Nivolumab plus ICE chemotherapy, also well tolerated, also highly effective, also the majority of patients successfully going to transplant. Notably, when a large collaborative study was done looking at what drugs you got just before you went to transplant and did it make a difference, if you received a PD-1 antibody containing salvage treatment before transplant compared to standard chemotherapy or a brentuximab containing regimen, you had a better outcome. So the blue line at the top are patients that receive PD-1 blocking antibody. So for me, the takeaway is that if the patient has not received a PD-1 blocking antibody, they should receive that as part of their salvage treatment prior to going to a stem cell transplant. So finally, what's important if you've had these other therapies and the patient relapses post-transplant? What are the options and what looks promising? So large cell lymphoma, other types of B-cell lymphomas, as you are hearing or have heard, have shown really substantial results with CD19 targeted CAR therapies. The challenge has been that in Hodgkin lymphoma, we've been a bit behind, and the results have not been quite as stellar. So here is some data from a CD30-directed CAR. I would say response rates have been promising, but durability of response remains a challenge. And so I would say this is still a space where there's a lot of work to be done. Well, PD-1 blocking antibodies and checkpoint inhibition have been really important. So how about different ways to enhance checkpoint inhibition? So this was a second checkpoint added to pembrolizumab, which patients had already failed, and this is faverilizumab, which is an anti-LAG3 antibody, simply showing that a dual checkpoint inhibition strategy in these patients, while not having everybody respond, had a respectable 30% overall response rate in people that were already refractory to PD-1. So that's a strategy that I think has promise for the future. And finally, bispecific antibodies may have a role, and this is AFM13. This is a CD30, CD16 bispecific. CD16 binding to monocytes and NK cells, CD30 targeting the Reed-Sternberg cell. So in this case, what they did was they took cord blood cells, isolated NK cells, and activated them and pre-treated them with the bispecific antibody. In essence, putting on the antibody onto an activated cord blood NK cell. As you can tell, response rates were extremely high. Overall response rates in the 90s, CR rates in the 60s. Challenge, however, being, again, durability of this particular therapy, but I think this is a promising future strategy. So with all of that said, what do I hope that you'll take away from our discussion today? The new agents, PD-1 blocking antibodies particularly, but also brentuximab vedotin, really being incorporated now into frontline therapy. We're kind of back to the future, if you like. In the old days, we had ABVD versus escalated BIACOP. Now we're to Nivo-AVD versus BRICAD. But both of those really look very promising. In second line, if you haven't had, as a patient, had treatment with a PD-1 containing regimen, you should receive a PD-1 antibody prior to going to transplant. And finally, if patients relapse post-transplant, consider a clinical trial because we really need to bring new therapies to bear in those patients. So with that, I'll thank you for your time and attention. Happy to take questions at any point.